So Brian is a very active, healthy 23-year-old adult who had a 1-month history of neck pain, and he was on some pain medications when he came to the Morris Hospital ER. He was admitted to the outside hospital with 1 hour last known well time with acute right-sided weakness and slurred speech. So when he came to the Morris Hospital, we went over the inclusion-exclusion criteria with Dr. Kreiser and his team. The CT was negative. So he was in the window for IV TPA, which we did give him at the Morris and then transferred him over to us. When he came to us, he actually had 2 events that made me think, and our team, that he needs more intervention and the TPA might not work for him. We just, as I pointed out to you earlier, last year we had the 3T MR, and one of the advantages of 3T is that we invested a lot of resources in a software which can help us identify patients who are even more candidates for aggressive intervention if they fail IV TPA. And as you can see, the perfusion scan showed that there was a huge area of mismatch in the back part of the brainstem and the cerebellum in Brian's case. And when he was getting the MRI, he actually went out like a bulb. For a few seconds, we had to pull him out quickly, assess him again. He turned around, and then we decided at that time we already had enough images to identify what was going on, and we decided to take him straight to the neuroangio. But since he had already received the IV TPA, one concern is always there. What if he had bled from the IV TPA? And the MR, we were only able to get the pertinent sequences because he was deteriorating and he was fluctuating. So we decided to abort the complete MR sequence, and we took him straight to the angio. We did a non-contrast CT, which confirmed that there was no bleeding in his case. And then we did the angiogram, and you can see from all these images, but I'm just going to show you the pertinent ones. Image on the far left, on the lower side, you can see that there are some areas which are showing up on the MRI diffusion, suggestive of an acute ischemia in the brainstem. And then on the angiogram, this is the basilar artery, which is totally occluded. And the most likely reason for his stroke was the fact that both his vertebral arteries were dissected, which is basically a tear in the wall of the vessel, and most likely generated a clot from there, and it went up and occluded the complete basilar. What happened after giving him 8 milligrams of intraarterial TPA, the whole vessel opened up, and then this is a repeat MR, and you can see there is an additional small area of stroke on the left side, which was clinically silent, because when we lyse the clots, there's always a risk that they can propagate more distally. But immediately after the procedure, he returned to his normal baseline, and then he was discharged home very quickly also. So, and now I'm going to ask Dr. Kreiser also to give his part, and also the EMS representative to just like talk to you all about how it all transpired when they received him and subsequently thereafter.
Hi, my name is Adam Hughes. I'm with Shannon on Fire. One of the things that most of you don't expect to get called for 23-year-old stroke patients. Tried to get them loaded up and get them going to Morris Hospital. They were running some tests, and then we got the word from Dr. Kreiser, who can kind of paint the rest of the picture for you.
23-year-olds don't have strokes. Let's just start with that. And so the initial call and presentation was for a 23-year-old with weakness. Brenda Keener, one of my physician assistants, was in the room as soon as the ambulance got there, and that was followed by 3 different members of my staff saying, you need to get in here now. The parts that were most impressive to me were the family and the friends who insisted that he had gotten up and he was fine in the morning. And that's what made the difference, because it gave us a definition of our window. And it allowed us to say this is an acute event. The 2 hardest things that I had to do was, one, for all of you who are familiar with TPA and the risks and the side effects, to have a 23-year-old and say, and have Dr. Bashir on the phone saying, yeah, I think he should get TPA. And my only thought was, yeah, I wish you were here saying that. And the other was his parents, who kept saying, is he going to be okay? And the answer is here, and from what everybody did. And we went from a 23-year-old who doesn't have a stroke to a fine young man who looks like he's going to be just fine. So it was great teamwork by everyone.
Thank you so much.